Okay, hello everyone, and welcome to another session of the Virtual Global Spine Conference. My name is Ali Baj, and on behalf of the Virtual Spine team, I am excited to welcome our guest today, Dr. Meng Huang. Dr. Huang is an assistant professor of neurosurgery at Houston Methodist Hospital in Houston. He completed residency training in Methodist, and after which he pursued spine fellowship training at the University of Miami, and then returned as faculty several years back at his home program in Houston Methodist. Dr. Huang is, I was going to say slowly, but actually quickly and rapidly becoming a thought leader in spinal endoscopy. He has a strong interest in minimally invasive spine and spinal endoscopy work. And we're absolutely thrilled to have him with us, as a lot of you who follow us either live or on YouTube. Everyone knows that we're very big into enabling technology and innovative techniques on this platform. So this is probably, I would say it's the ninth or 10th session on endoscopy just in the last year and a half or so. But it's such a rapidly evolving area that we can't even catch up with it. So we're absolutely thrilled to have our guest today to shed light on the latest and greatest. And Dr. Huang, thank you so much for joining us on Virtual Spine, and welcome.
Ali, thank you so much for this invitation. It is a huge honor to be here, of course. Your Global Spine Conference platform is an amazing resource for everyone and all people and students of all walks of life to learn more about spine surgery, and I think this is an outstanding conference that you put together. So thank you for having me. So I will talk about the spine endoscopy, and the title is Why It's Not Just Hype. And I say that because there's more and more interest, but at the same time, I still feel like the interest is not as high as I would expect based on my own experiences with endoscopy. And so I'm kind of going to share with you my thoughts about that, and we'll of course go through some cases which I really think are unique to endoscopy, and hopefully we'll continue to help drive the endo train forward, so to speak. I know Professor Luke Kim, the spine walker, gave an excellent talk last week on endoscopy. So hopefully this will be at least live somewhat up to his talk. And so with that, we'll get going. I have tons of slides. You can stop me whenever you want. I'm happy to answer questions anytime. So I figured I'd start off with a few evidence slides. This is probably the most recent, very comprehensive literature review meta-analysis from JNS 2019, looking at outcomes of endoscopic discectomy versus tubular microdiscectomy versus open microdiscectomy. And this was written by actually one of my partners, Sean Barber, and then also Sanjay Konakandla, who's been on the show before, the Zoom before, and their mentor was Albert Telfian. So this was a very large meta-analysis of data gathered in February of 2019, looking at 26 studies, 2,500 patients, 11 RCTs, 5 of which were endoscopic. And what they showed was that basically the primary outcome scores that we're accustomed to, that we typically look for, VAS, leg scores, back scores, ODI scores, all favored endoscopy. The length of stay favored endoscopy, return to work favored endoscopy, complications including durotomies favored endoscopy, EBL favored endoscopy. The only thing that didn't was reoperation for residual disc. So even though a lot of those results favored endoscopy, at the end of the day, the magnitude was not that big. And so is there clinical relevance to that? So that's a fair assessment. This is a randomized controlled trial from 2022 out of China, looking at a transforaminal endoscopy versus micro endoscopic, which is basically just a tubular discectomy, right? But this also had a 5-year follow-up. So single center RCT prospective. to nearly 250 patients, about 120 in each group, with 80% follow-up at 5 years. So when you look at their outcomes, the primary outcomes are the PROs that we all are very accustomed to. Those are basically the same, meaning everybody does well with these operations, and endoscopy is not inferior by any means. Recurrence rate was the same. But again, even though both are efficacious, the long-term outcomes are comparable. Are these results, is the difference, is there any clinical significance to this? The main advantages are, of course, less invasiveness and a faster recovery. This was an RCT conducted in Amsterdam, a Dutch trial, published in the BMJ in 2022, 600 patients with symptomatic disc herniations after 6 weeks of conservative therapy. They had some learning curve patients as well, which had subgroup analysis also. And the primary endpoint, again, was VAS scores, right? So looking at the primary endpoints, their results were actually significantly better with endoscopy. But again, is a VAS score of 1 versus 2.5, does that make a big clinical difference? And so that's the main problem, is that it's hard to show clinical significance, even though some of the data can suggest that the outcomes are better. We at least know that endoscopy is non-inferior. But what about complications surrounding endoscopy? So this is a great publication by Mark Mahan, Albert Telfian, Christoph Hofstetter, Osama Kashlan, Ralph Wagner, and various other endoscopists around the world, actually. And they were looking at a surgical site infection. So they looked at about almost 1,300 patients who underwent endoscopic discectomies and compared them to a propensity-matched cohort of 6,000 open patients from the NSQIP. And so with their study, they found that you're 16 times less likely to develop a surgical site infection with endoscopy, which that's a pretty big deal, because anytime, even though infections are rare with open microdiscectomies, if you do get one, that discitis and osteomyelitis can be a huge problem, right? And then as far as other complications go, all comers, 1.7%, less than 1% durotomies, epidural hematomas. They only had about 4% recurrence rate of disc herniations in this particular study. What about socioeconomic impact? The same Dutch study looking at their cohort, ultimately, all of these costs are very trackable in the Dutch system. They have a socialized healthcare system that allows them to pull this data as far as the cost equivalence. And so if you look at the total healthcare cost, endoscopy is a little bit more costly up front, but on the back end, it's actually less costly because these patients return to work faster and they don't need as many medications. They don't need physical therapy, all these things. So ultimately, you've seen a lot of what I would describe as lukewarm data. And so the problem with the current data is that we're looking at VAS and ODI scores, or PROs, at 1 year. So that really doesn't capture the true benefits and the potential of endoscopic surgery, right? I mean, you can go from point A to point B and arrive at point B with the same technique, but the journey there matters. And if the journey can be improved, I think that's something that is notable. So, with endoscopy, you have the ability to avoid general anesthesia and nearly eliminate postoperative narcotic consumption and therefore return to work earlier. That's a big deal. There's reduced hematoma, infection, CSF leak, and reoperation costs, and that's a big deal. Long-term segmental stability. When we do transforaminal surgery, we are completely preserving the normal structural anatomy, meaning there's no laminotomy, there's no ligamentum flavum resection, there's no medial facetectomy. So, even though this is something that would be very hard to prove with an RCT with 20-year follow-up, I mean, that's unrealistic, right? But at the end of the day, I think it's very reasonable to assume that long-term stability will be much better by preserving these structures. Obviously, you see patients in clinic in follow-up after 10, 15, 20 years after a microdiscectomy, and you see that one level is completely collapsed. there's an asymmetric collapse, there's the beginning of a fractional curve, et cetera, right? And so, of course, preserving those structures will make a difference. And then along those lines, the benefits of avoiding and perhaps delaying a larger fusion surgery can be done with endoscopy. And then, of course, that decreases the morbidity of treating certain conditions, which I will highlight later. So I'll take a quick second to shout out the Endoscopic Spine Research Study Group headed by Christoph Hofstetter. We are actively collecting prospective high-resolution clinical data via the app that he developed called Spine Healthy. This allows us to collect PROs basically on a daily basis post-operatively for the first week, then at 2 weeks, then at 1 month, 3 months, 6 months, and yearly after that, and pairs it up with biometric data, including their step counters as well. So we're actively collecting that high resolution data that I think we need to push us to the next level. So just as an example, this is a patient who underwent a C6-7 posterior cervical foraminotomy and discectomy done full endoscopically. And so this is an actual patient. And if you look at these PROs, the peak recovery was achieved on post-op day 1, right? The patient had very little surgical neck pain and didn't take any narcotics. And then that's been sustained ever since. This is a very large paracentral L5-S1 disc herniation that I treated with an interlaminar approach. And again, you can see that they were extremely debilitated pre-op. And their peak recovery was achieved essentially on the day of surgery, and on post-op day 1, everything returned back to normal. And again, they went from taking narcotics to just taking muscle relaxers for 2 days. Transforaminal L5-S1, I had a patient who happened to have both an extraforaminal free herniation and a paracentral disc herniation at L5-S1, compressing both L5 and S1 roots and having symptoms of both. And so this patient underwent a transforaminal discectomy to take care of both pathologies all in one trajectory. And so again, you can see that these patients have very little back pain at all from surgery itself. They go from taking narcotics to only taking muscle relaxers, and their peak recovery is achieved very quickly. So the indications are very broad for endoscopy. You can essentially do endoscopic decompression of anything you want that's degenerative in nature. And I've highlighted these in green because these are where I think endoscopy really can make a big difference, and I'll show you why. There are all sorts of other things and interesting pathologies that you can start to treat with endoscopy. And one of the things I want to highlight, and you'll see, is the treatment of the frail, elderly, and the cardiopulmonarily compromised patients where you can do awake surgery. So we'll start off with lumbar spine. This is just a schematic to demonstrate that the laminar window becomes larger and wider as you go down the lumbar spine, and whereas the foramen get larger as you go up the lumbar spine. So transforaminal is great for L4-5 and above. I typically go interlaminar at L5-S1 for these reasons. I have my own approach algorithm for how to treat disc herniations depending on what level they're at and where they're migrated in the zone of migration. But this is a separate talk in itself, and you can see that on the SSF channel. So I'm going to show you some cases, and these, of course, are not going to be bread and butter paracentral L4-5 disc herniations, right? These are cases where I think endoscopy really makes a difference. So this is a 59-year-old male with 1 year progressive low back pain radiating to the left groin and proximal anterior thigh. He'd failed conservative measures. And so you see this large paracentral disc herniation at L1-2. And if you think about this, at L1-2, the interlaminar window is very narrow. And even if you're an extremely, conscientious surgeon, I think you will still potentially get into trouble taking a dorsal translaminar approach here to get this disc herniation out, because you may compromise and destabilize this facet joint. And so it makes a lot more sense if you can go straight to the point through the foramen, because once you go transforaminal here, you're landing on the disc herniation. So this is a brief video of what that looks like. So cranial is to the left, caudal is to the right. The L2 pedicle is going to be on the right. And what I'm showing you is, you see the bone at 12 o'clock is the ventral SAP. And here's the thecal sac and the transiting nerve root. I'm removing the disc herniation. And at the end, what you realize is you can see everything. You can see the thecal sac and you can see the ventral dura all the way to the other side of the spinal canal. So now you've got complete decompression that's directly visualized with pulsating dura, and we've violated no structural elements at all. So that's where I think endoscopy comes in very handy. Similar case, 77-year-old female. She's got known chronic lower lumbar problems. She lives alone, independent, drives, all that. But she was brought in by her family because for the last 3 weeks, she had acute worsening and really couldn't walk. She was completely bedbound, severe bilateral radiculopathy, urinary retention. And so this was a CT scan when she first came in. Again, she has known chronic issues at L34, L45. But the biggest thing that was new was this very large, expansive, central, cranially, caudally migrated L12 disc herniation. So again, if you look at the anatomy here, this facet joint is extremely vertical. The laminar window is extremely narrow. So any sort of primary decompressive surgery will very likely compromise that facet joint and destabilize her. And so again, if you can access this transforaminal and take care of it, it makes a huge difference. So this is an intraoperative picture inside the scope. We've got the orientation here, rostrals to the right, caudals to the left. And this is a right-sided approach, so we can see the pedicle of L2, the ventral SAP, and then we're accessing the spinal canal. Here's a drill. I'm widening the foramen a little bit. You can see epidural fat, the dura behind it, the ligamentum flavum, the PLL. And now you can see the thecal sac. I'm dissecting underneath the thecal sac. All the disc herniation comes out because it's the path of least resistance. I'm able to use semi-flexible graspers to get it. And I can reach all the way up and below the herniation and all the way across to the other side. And here's the final picture, the traversing route, the ventral dura, everything is nicely directly visualized. Now the thecal sac is rebounded, and you can actually see the dorsal part of the thecal sac in addition to the ventral side. And so if you look at the postoperative films here, this is a complete resection of this disc herniation and decompression of the conus medullaris and all the cauda equina. And the only evidence that I was there is this little bit of facet that was removed, which is non-articular in nature. So that converts a guaranteed fusion operation into a non-fusion operation. I think that makes a big deal. Here's a 28-year-old male. He's got 2 weeks of first left, then eventually right-sided radiculopathy, and he comes in with 1 week of right foot drop. And so he has a very large central disc herniation at L4-5. Interestingly, he's got an annular defect on the left-hand side, and it looks like the herniation is coming from the left and migrating centrally and then to the right. And so again, I think there are lots of talented surgeons that can pull this off with a tubular retractor with maybe a little bit of medial facetectomy, but it also wouldn't be wrong. And I think a lot of surgeons would approach this with a full laminectomy. But in a 28-year-old person, knowing what we know about degeneration, if it were my spine, I wouldn't want any degree of laminectomy, ligamentum flavum resection, or facetectomy, especially facetectomy, if it wasn't totally necessary. So this is a left-sided transforaminal approach. You can see the targeting. And I went to the left because the extrusion is from the left and the annular defect is on the left, even though the foot drop was on the right. And I'll show you that we can actually visualize the contralateral side of the canal decompress. So here we are, left transforaminal approach. You can see the arch of the SAP and the pedicle on the right. And we are immediately, once we get in the lateral recess, and this is the disc herniation. And so we're immediately able to access the disc herniation. And you can see that even with a small 7.5 millimeter endoscope with a 4 millimeter working channel, we can pull out massive disc herniation fragments. And again, that was the primary fragment. There's a secondary fragment as well. And what's very interesting, if you pay attention to what's coming up now, is first of all, we're going to see the lateral recess completely decompressed. And that's the traversing nerve root right there pulsating. But through the existing annular defect, we can actually put the scope into the disc and look across the other way. So if you look here, it's a little bit hard to see, but you'll see it here in a second. This is the contralateral lateral recess pulsating and the ventral dura pulsating on the other side. So we know we've decompressed the entire thecal sac including the contralateral side by visualizing this. And so, the other advantage I think of this approach was that, we're pulling the disc away from the injured nerve rather than retracting the nerve and then removing the disc herniation. And so you can see on the postoperative imaging, the patient has absolutely no sign of collateral damage to the spine after treating this. And so I'd like to think that I've potentially saved him from any future issues at this level. Obviously, time will tell, but at least I tried my best there. So this is an interesting case. A 68-year-old male with 1 year progressively worsening right lower extremity pain. He's got anterior thigh pain down to the knee that stops at the knee. He has no back pain. He's a former pro athlete. He plays golf. He's exhausted standard conservative therapies, and he had a temporary relief with a right L3-4 transforaminal epidural steroid injection. He's got a very common problem in the aging population, a degenerative scoliosis. And he's got severe foraminal stenosis on the concavity. So this is the L3-4 level with severe foraminal stenosis and a calcified extraforaminal disc herniation. So you can see not only the disc herniation, but the tip of the SAP abutting the exiting nerve root. Unfortunately, you look at the rest of his spine, he's got intradiscal air at every single level. Everything looks horrible, and he's been offered a multi-level fusion by several other surgeons, but he just has leg pain, and he would like to try something less invasive just to treat that. So again, if you have endoscopy in your tool set, then this is something that's very treatable. So this is the post-op CT scan. You can see that what I've done is I've completely removed the tip of the SAP without compromising the facet joint articular surface, and I have removed the extraforaminal disc herniation. So this allowed decompression of his nerve, and he's almost a year out sustained playing golf without any further leg pain. And so that's something, again, I think makes a huge difference, and you've converted a guaranteed multi-level fusion into something that's an outpatient surgery. And, some surgeons may claim that they can do this with a tubular retractor or whatever, but I think that would be very difficult to not compromise the facet joint, even with a lateral tubular approach. How about awake lumbar discectomies, right? I alluded to that earlier. This is a 90-year-old female with chronic low back pain with 5 months of debilitating left anterior thigh pain. She's been turned bound by 2 other surgeons due to her age. She's mentally sharp. She's concerned about short and long-term memory loss from undergoing GA. Very understandable. Well, endoscopy is a great tool in this case, right? She's got a disc herniation at L2-3 with a concordant radiculopathy, and we're able to access this transforaminally. So this picture is actually just a picture of me performing a TLIP block before accessing. This is intraoperatively accessing, and here's a brief video. And so you can see the approach here. Again, we're taking a left-sided approach. The L3 pedicle is on the right. This is the arch of the ventral SAP that I'm able to burr down under direct visualization. And after this, we expose the lateral recess. I've removed the ligamentum flavum in the lateral recess to expose the transiting nerve root. You can see that it is tented up. And after that, I can lift it up and I can access the disc herniation underneath. And so she's sedated, but semi-conscious and able to interact with us, which makes transforaminal surgery much safer because we can tell if we're being too aggressive on the nerves, and especially on the exiting nerve root during the access and the approach. And so this is very low risk and high reward for somebody who was afraid of general anesthesia. And what's interesting about this is, you look at this, and from the time the case finished, it only took about 15 minutes for her to get out of the room because she helped herself get off of the table. And she was only in recovery for about an hour before making it to the outpatient area. And in the outpatient area, it only took this 90-year-old, 50 minutes to pee, walk, and get dressed and go home. So this is a case where endoscopy makes a huge difference. How about awake lumbar laminectomy? Same thing, 65-year-old male. He underwent 2 mild procedures with pain management, didn't have any benefit, super mentally sharp, super active, not able to walk very far anymore, and he's a major traveler and a hiker. And he's very concerned about memory loss from general anesthesia. He's got only one level severe lateral recess and central canal stenosis at L4-5. This is post-mild, and the pre-mild MRI looked exactly the same. I'm hoping that you guys can hear this. This is an MRI, or not, sorry, this is an intraoperative video that was taken on the phone. And he is awake right now, actually talking to us this entire time. And I recorded this video just to send to him afterwards. And so I'm narrating the end of the case and showing him the anatomy. And you can see that I accidentally will bump the nerve on the contralateral side, and he'll jump a little bit. But otherwise, you know, this is a very well tolerated surgery when you have a very small surgical footprint. And we look all the way to the top to the other side. And on the other side, we are in lateral recess as well. Lateral nerve right there. And then there's the nerve passing the tunnel down here. So I'm right now on the nerve right there. I actually, sorry. And so I hope you could hear that. I apologize because I bumped his nerve and he jumped. So again, this is a great outcome and very quick transition from OR to recovery. Very quick transition from PACU back to outpatient area, and then very quick discharge criteria. So again, this is the pre-op, and here's the post-op complete decompression achieved. And the other benefit of the endoscope is that, you know, I think when you put a large 16 or 18 millimeter tubular retractor, you get pushed laterally, and you end up taking more. You look more medial, and you end up taking more facet joint than you actually think you do, doing it with a metrics tube. But with the endoscope, with the smaller scopes, these are 15 degree to 20 to 30 degree angled, and so you can actually start more medial and look more lateral to undercut without compromising as much facet joint. So again, you know, these were his incisions from the mild procedure that he had, and then this was the endoscopic incision. So very little morbidity there. Thoracic. Okay, so this is the most comprehensive endoscopic review on thoracic endoscopic treatment of thoracic pathology. And this is, again, this is where endoscopic surgery makes a huge difference, right? So in this review, and I'll just go through this very quickly, this is a case series of 17 case studies, one cohort, 13 case reports. The majority of these cases were transforaminal, and the majority of the pathology, of course, was disc herniations, but stenosis and ossification of the ligamentum flavum and tumor and discitis was treated as well. These patients had overall good outcomes, and the complications were overall pretty low. Now, compare that to thoracotomies and lateral extracavitaries and costotransversectomies. The complication profile is much higher with those. So, you know, there is low level evidence to suggest that full endoscopic thoracic discectomy is a huge value add. So this is a case example, and I'm just highlighting my chief of spine and my good friend and mentor and partner, Paul Holman. This is his patient that he got me involved in. This is a 71-year-old man, hard worker from the countryside. He lives on his ranch and is still moving heavy bags of feed. He had abrupt onset mid-back pain with radiation to both legs. About 2 weeks prior to presentation, he had bilateral numbness, tingling, gait difficulty, several falls due to his legs giving out, and now he's unable to walk unassisted at all. He's got urinary urgency. He's got significant left-sided proximal left leg weakness and increased reflexes. And so I apologize for the quality of this MRI, but basically you can see that there's a large central paracentral disc herniation at T910. And you can see that the spinal cord is compressed and displaced to the right side, and the left side of the cord is compressed. And there's a large central component to this. So this was not calcified, fortunately. Not that you can't treat calcified disc herniations and endoscopically, you absolutely can. So this is a video of how that's done. This is a transforaminal approach. Rostrals to the left, caudals to the right. And this is our entry into the lateral recess. The pedicle of T10 is to the right, and right now I'm kerosining the medial edge of the SAP. And so as we work to open up the foramen and the lateral recess more, we start to actually see the disc herniation. And we also see the epidural fat, which tells us the plane that we need to be working in, which is underneath that. And so once we start removing disc herniation, then we will start to see the epidural plane start to drop into view. So here, as we remove the disc herniation, the epidural plane drops into view, and we'll highlight that with a little cutout. You can see the epidural fat, the PLL with vasculature, the herniated disc, the SAP, and the pedicle complex. And then we're able to continue to safely work essentially sub-PLL, sub-annular to remove the extruded fragments. And we're doing widening the exposure a little bit. And drilling is very safe with a diamond burr in endoscopy. The irrigation pushes the dura away. It's unlikely to abrase or tear the dura with a drill. And again, we keep on slowly dissecting and working. And as we remove the pathology, then the thecal sac and the traversing nerve root will start to drop into view. So as we continue to take the final pieces out, we can now start to see the thecal sac and the epidural space pulsating. And as we start to dissect, we can then visualize the thecal sac. So this is the thecal sac deep. And what I'm retracting with the dissector is just the PLL. And so after the final disc herniation fragments are removed, then we've got a completely pulsatile thecal sac, and you can actually see the ventral dura and the cavity that once was created by the disc herniation. So, this patient was admitted to the hospital from clinic, and so that's why he stayed in the hospital. If this patient was less myelopathic, that obviously would have been an outpatient surgery, but he reported essentially no surgical pain, and he passed his physical therapy immediately. Calcified thoracic discs, I don't have an example on hand. I've done a few, but the real expert at calcified thoracic discs is Sanjay Konakanla, so you can see his literature on this. Cervical spine, also great for endoscopy, and this is why learning the interlaminar approach is important, because obviously in the cervical spine, the only access approach is interlaminar. So this is a patient, 77-year-old elderly with 3 months of severe right upper extremity pain. That's the main reason why he's here, but he also endorses many months, perhaps a year of myelopathic symptoms with numbness and tingling in both hands and some balance difficulty. So when we look at his MRI, we see that he has central stenosis at C3-4, but he has a very large foraminal disc herniation at C7-T1, causing significant compression of the right C8 nerve root. And so he's got pathology that corresponds to both of his issues. And we felt that an endoscopic decompression would be enough for him. And so here's an example: full endoscopic right C7-T1 foraminotomy discectomy. The foraminotomy is already done here. You can see the C8 nerve root tented up. You can see the large disc herniation. Everything's nice and beautifully visualized. The counter pressure from irrigation will eliminate most of the pesky venous plexus bleeding that you typically see with an open foraminotomy. And so you can see that we're able to dissect and tease out all the disc fragments and complete the discectomy without any difficulty here. And at the end, you see a nice relaxed nerve root. And then we can easily then transition and retarget the L3-4 space. And once we get down to the L3-4 space, we can do the same thing. This is the interlaminar window. C3 is to the right, C4 is to the left, and all we have to do is drill circumferentially. Endoscopic laminectomies are actually much easier in the cervical spine than in the lumbar spine because there's less drilling that's needed. You can see I've drilled around the ligamentum flavum, separated it, and now I'm detaching it and removing it on block. So after we remove the ligamentum flavum on block, then we can see the entire spinal canal centrally decompressed all the way to the other side, and we can reach across and decompress the other side as well. So again, this is the preoperative imaging, and you can see the postoperative imaging reveals complete decompression and very little disruption of normal elements. And so this patient had a great outcome and very little scar to show for it, and no narcotic consumption after surgery. How about interesting cases? So we'll move to the final part of the talk where we show unusual cases that are well addressed by endoscopy. So this was a retained lumbar drain catheter of one of my cranial colleagues who was doing a brain operation, and the lumbar drain fractured off and was floating around inside, and we felt that it was best for this to come out from a medical legal standpoint. This catheter fragment, I noticed, since I look at things with through an endoscopic lens, I noticed that the tip of the catheter was definitely extradural in the lateral recess. So this was, to me, a perfect chance to try and get this catheter from an extradural transforaminal approach. And you can see how large this patient was. This would not have been a fun laminectomy. So this is published if you want to see the full video. Cranial is to the left, caudal is to the right. We took a transforaminal approach and had minimal disruption of normal structures, and we easily identified the tip of the catheter in the lateral recess, and we were able to remove this without any issue, and the patient was saved from a laminectomy. So again, a huge value add here because of endoscopy. How about repair of ventral CSF leak at T12L1? This is a 48-year-old female nurse, previously completely active part of society, but developed spontaneous onset postural headaches, and she's been incapacitated for 5 months. She can't drive, she can't work. She's failed multiple blood patches just done in the lumbar spine. And finally, she made it over to me. We ended up getting a digital subtraction myelogram that showed that there was an active leak coming from T12L1 right here. And you can see that there's a disc osteophyte complex centrally, paracentrally indenting the thecal sac and causing the leak. This is a pretty difficult case to treat from a traditional standpoint, right? I mean, you have the spinal cord there. You could do a small laminotomy and then reach around blindly and pack off some Duragen and hope that that fixes it. If you want to take a more lateral approach, you would have to remove the facet joint to directly visualize that area and thus commit her to a fusion. So this is not an easy case to treat without the endoscope, but with the endoscope, you can see that I can access this area easily. I can drill down that osteophyte to completely remove the offending agent, and then I can repair the dura. So this is after drilling away the osteophyte. I've identified the ventral dura and the ventral defect. You can see the rootlets herniating out of the ventral defect there. So now I can easily pack this area off with Duragen and seal this, and then that solves the problem with essentially an outpatient surgery. Unique approach to rostral herniated disc. This is a 76-year-old male who had an L4 to S1 laminectomy 16 years ago, chronic mild foot drops and surgery, but he developed acute recurrent lower extremity radiculopathy 6 weeks prior to presentation. He had a worsening foot drop and L5 symptoms. So here you can see that he's had a prior operation, but there's a cranially migrated disc extrusion from L5S1. So you can see the nerve roots on both sides, and then the extruded fragment. Again, here's another picture of the extruded fragment. It's compressing the exiting L5 nerve root up against the L5 pedicle. So this is a very difficult place to reach. He's had a previous laminectomy, so the interlaminar window is scarred and will be difficult to access. And cranially migrated disc herniations at L5S1 are essentially impossible to get to because of the iliac crest. And so, what would you do here? So this is where I pulled a unique approach out of the bag, which was first described by Menno Ippenberg and colleagues, including Albert Telfian, and that is a transpedicular approach. So this herniation is pinning the nerve root up against the pedicles. So my plan was to just completely go through the pedicle. So this is a very far lateral transpedicular access where I'm putting a Jamshidi needle directly through the pedicle, almost like putting in a pedicle screw, but going even more laterally and going through the lateral wall of the pedicle. Here I am reaming through and placing the working cannula. And so now I'm able to get into the canal through the medial pedicle. And so this is a quick video, cranials to the left, caudals to the right. I'm completely within and encased inside the L5 pedicle here. And so I'm going to drill and drill until I breach the medial wall of the pedicle. And once I breach the medial wall of the pedicle, I am going to see immediately the pale ischemic nerve root. I know that the nerve root is getting compressed up against the pedicle, right? So here I'm able to expand the pedicle. And once we expand the pedicle, then we will be able to identify the nerve root better. And now you can see that the nerve root is a little bit more relaxed now, just by virtue of the potential space created by the pediculotomy, and it's becoming vascularized. And now I can lift up the nerve root and find the disc extrusion. So now I can tackle and remove the extrusion by working underneath the nerve root. And so we're able to remove all of the fragments very easily here. You can see it's coming out through the path of least resistance. And in the interest of time, I will kind of skip along here, and you can see the pale ischemic root become well perfused and pulsatile at the end. And this is the follow-up. And you can see on the follow-up MRI that extrusion is completely gone. Again, another lumbar foraminotomy case. Very briefly, this is a patient who had obviously an old, I think that's a Steffi plate fusion from decades ago, and he's developed severe foraminal stenosis at an adjacent level that's still mobile and not autofused, with a large extraforaminal disc osteophyte complex. And so again, this is something that's easily accessible with the scope. He had only radiculopathy. And you can see here that I can actually drill away. This is an intraoperative O-arm CT scan afterwards. You can see that I can drill away that part of the SAP that is causing the compression, and the entire foraminal calcified disc herniation with the burr, while protecting the exiting root and achieve the desired outcome. So in summary, endoscopy is here to stay. Any open decompression can be done endoscopically. There's a decent amount of evidence. You've seen a lot of RCTs. There's not a lot of spine subfields that have RCTs other than arthroplasty that show improved outcomes that are at least equal, if not better. Complication rates we know are significantly lower. There's a lot of intangible benefits that will be impossible to prove with long-term RCTs. Certainly, the patients can go back to work earlier. That has a personal and societal impact, especially the person is a primary breadwinner. That makes a big difference. But better long-term stability is one that I really hang my hat on. I think transforaminal access is amazing for preserving segmental stability. And I think that if you can achieve that, then there should be no reason to perform laminotomies and medial facetectomies. Decreasing the necessity of fusion surgery, that's always a plus. And then treatment of those who are ineligible for general anesthetic. Value-based care, I think, in this country will eventually increase the demand for endo, and there's already a ton of patient demand in my practice, and then payers, I think, will eventually see that too, especially with our Spine Healthy ESRG prospectively collected data that will be coming out in the coming years. And competition will eventually drive down the cost and barrier to entry here in the US, where the equipment is very expensive. And we already have other companies entering the fray here. And so I think it's just a matter of time. Fellows now are becoming more and more interested and engaged in endoscopy. And so this is a cliche image, but I really do think that if you're a trainee nowadays and you're not incorporating endoscopy into your practice when you get out, you will already be a dinosaur, because I guarantee you this will become much more mainstream in about 5 to 10 years. And so with that, I will end the talk and field any questions that you may have. And again, I thank you for this opportunity.
Thank you so much. Thanks, Dr. Huang. That was really excellent. Exactly what we thought you would deliver. A very compelling perspective on why endoscopy nowadays is just so valuable and so useful. I like what you said at the end. I would agree with that. A lot of our trainees, a lot of trainees around the country, really that's what's missing for them. They're getting the complex spine, they're getting the fusions, the trauma, and a lot of them are searching for extra or additional endoscopy training. So this area is definitely going to further expand. And I think I kind of share a little bit of work online with social media and whatnot. And I put this the other day. The reality is, if you're a competitive academic spine program out there, you really need to have a strong endoscopy program to be part of it. It's just nowadays you can't just you've got to incorporate endoscopy into an academic spine program. So a lot of great work. I got one question for you, if you don't mind, and
Sure.
we'll see what other questions come from the audience. But you've talked a lot about the decompressions, obviously, and that's what I think a lot of people talk about, right? The cervicals, the lumbars, even the thoracic discs. But where is this heading in 5 to 10 years, right? What are the hardest things for maybe people like me and others who've done MIS discectomies, use a 14 or 16 or 18 millimeter tube and get the job done? Okay, incrementally, is there a significant advantage to using an endoscope? We're not, a lot of us are not seeing that yet for decompression. But what I'm excited about is, okay, well, what does it look like in 5 years or 10 years? Are we going to be able to do a lot more fusions and corpectomies and tumor work, et cetera? So where do you see this going beyond degenerative decompressions?
Yeah, I think no, that's obviously the one of the main reasons why we're not taking off is because, as you know, all these studies that I showed are looking at bread and butter degen cases where, of course, the outcomes are going to be fairly equivocal. And so, is there a value add over somebody who's already good at MIS tubular surgery like yourself? And the answer is no. You're absolutely right. Is it worth it? Probably not. But the cases where I do think it makes a difference are the ones where I showed where I truly think it would be very difficult to pull off a decompression alone, such as in the upper lumbar spine, revision surgery, thoracic, things like that. But to your question about where this is headed, absolutely, I think there needs to be a less invasive way of doing fusion surgery too. In the fusion sphere, though, I think there's going to be different challenges that we face because at the end of the day, you and I look at decompression cases and fusion cases differently, right? I mean, when we're looking at fusion cases, we're thinking about alignment. We're thinking about end plate coverage. We're thinking about graft delivery, graft volume. We're thinking about a lot of things that are much more difficult, I think, to pull off endoscopically. Some surgeons are amazing at endoscopic fusion already, like Mike Wang, one of my mentors. So he has excellent results with his fusions. But he's a special surgeon, and not everybody is going to be able to pull that off. When you think about endoscopic fusion, at the end of the day, right now it is still basically a TLIF, right? And so there's a couple ways to do it. There's either uniportal, which is where you're using one port and doing all the work, including the access, the discectomy, maybe some decompression, and then delivery of the cage. And so with uniportal, no matter what you do, you will still be to some degree restrained by the portal size and the size of the cage that you can deliver. There are, of course, surgeons out there who can deliver even standard TLIF cages through uniportal endoscopy, like Jian Shen. He's an amazing endoscopic surgeon and fusion surgeon. But there are also other surgeons now adopting biportal, which is the other hot topic within endoscopy, is uniportal versus biportal. I think eventually fusion will head to the realm of biportal surgery, and not necessarily just biportal. You can think of it more as multiportal, where you can have a full working channel endoscope, not just a camera, and also have your hands using a standard instrument in another portal. And let's say you need a third hand, you could theoretically just make another stab incision and put another instrument down. So I think biportal does have advantages of being more efficient and quicker. You can imagine how hard it would be to take down an entire facet joint using a uniportal endoscope and how time intensive that would be. But with biportal, you get to use standard tools, regular instruments, large Kerrison, standard high-speed drills that are not limited by speed in some endoscopic cases. And so you can be more efficient and more comprehensive with your decompression and more expansile with your decompression with your TLIFs, and perhaps get bilateral endoscopic facetectomies to do a full release and generate the lordosis that you need to maintain neutral alignment or improve it slightly, even with a TLIF. despite the fact that TLIF has a bad reputation for not being able to generate lordosis. I do think it'll be possible. So I think the uniportal will be there for sure for decompression, and then I think eventually it'll be uniportal plus another portal, so multiportal or biportal, to address the fusion sphere. But I do think that's coming as well.
Wonderful. Thank you so much for that, and for an absolutely terrific session. We're excited to promote and disseminate this on YouTube, where I know many hundreds of viewers and surgeons and other spine enthusiasts will find this very useful. So, on behalf of the group, thank you so much, Dr. Huang, for spending this hour with us, and hopefully we'll have you back again in the near future to show us some more terrific cases and hopefully evolution of your current technique and practice. Thanks so much, Meng.
Okay, thank you so much. Take care.
Thank you. Take care, everyone. We'll see you next Thursday. Have a great evening.
Bye-bye.